Join us September 21st through the 23rd for the 2023 AMSN Annual Convention in fabulous Las Vegas, Nevada.
Double down on your commitment to our practice and to your patients by gathering with your peers and aspirational leaders for 3 days of learning and networking.
Don't miss the premier event for medical surgical nurses. Register now at amsn.org.
We'll see you in Vegas.
This is Neil.
Maritess.
Parker.
And this is Laura. Welcome to med-surg Moments, the AMSN podcast.
This podcast is an engaging look at the lives of and surrounding medical surgical nurses.
We're proud med-surg nurses just like you,
sharing our stories, insights, and experiences to support you in your nursing journey.
Hi, everyone. Our topic today is adventures in wound care. Lots of fun to come. Before we get started, let's play Rose and Thorn. Your rose being something that's going well, and the thorn is something that might not be going so well. Parker, why don't you get us started?
Hey guys. I recently became a premium member of National Geographic. I've been reading a lot of interesting articles because I'm a nerd like that. So it's been really cool, looking at National Geographic. They have expeditions and things you can go on. So I was looking into going on one of those next year. So that'll be cool. So that's a rose. So with thorn for me, it's going back to school, just anticipating all the work that I have to do. But I graduate in 2025, so I'm just going to keep my head up and complete my program. So Maritess, what's been going on with you? What's your rose and your thorn?
Before I share, Parker, you got this. Lifelong learners. It's hard to go back to school, but I don't know about us. We always want to continue learning. So kudos to you. Such brave steps to continue that academic journey. For my rose and thorns, I shared previously that I need to sit down and reflect. I'll share that still is not happening. It's just so hard to find time. And I always say, it's not finding time. It's more of making time. You have to make time. I always tell that to myself. You have to make time. I used to do that, but I don't know what happened after the pandemic. Nothing is too structured. I think that's what happened. I shared previously the kids from brick and mortar. Now they're all online. They're all traditionally homeschooled. And so there's really no structure. They're really more of doing their self-paced. And I think I kind of adapted to that. We always have how many minutes in a day? I don't count the hours. I always count the minutes. We have so many things that we can do, but not happening. So that's kind of like the real thorn. With regards to my roses, I would say roses. Why? Because even though I don't have time, I think I know what I wanted to do. I wanted to really explore my other entrepreneurial skills. I really wanted to continue testing different kinds of food to cook. I think I do have that skill to be an entrepreneur, but I don't know how to start it. But I think that's a good part. I'm not leaving nursing, but, just the other side of things. Neil, what's new with you?
I guess I'll go with the big thorn first. I actually had a really serious health scare. I know in one of our episodes I revealed I was a cancer survivor. All of a sudden, one day I woke up with some pain down in my genitalia area, and thank God, Dr. Travis Howe, my doctor here, he's my prime doctor, saw me within the day, had an ultrasound. The ultrasound showed a varicose vein down there, but when I went to the urologist to follow up with that, he wanted to get a CT of my abdomen and pelvis to make sure there was nothing growing down there. And then they found a slight pericardial effusion. So I went to a cardiologist, and the cardiologist has me coming up on getting an echo in the next few days. But it made me really empathetic to our patients, trying to get all these back-to-back appointments, the insurance, money, the time, and effort. I'm all by myself. I love my dogs. They don't get to drive me to appointments. After a long night of work and the nuts available, I'm going to jump on. That was a pretty big thorn. So on to the roses of all that, though. I started embracing life a little bit more coming up on year 50. I mentioned in an episode or two before that I just purchased a mountain bike. Well, obviously I haven't gotten out to use it with getting all these checkups. But I took a weekend trip out to the Outer Banks, which I've never been to, even though I've been down here since 98. And I went hang gliding at 2,000 feet above the Outer Banks, which was a pretty amazing experience. I highly recommend and suggest it. Laura, what's going on with you?
Wow, that's going to be hard to follow. But wow, first of all, Neil, thank you for sharing that with us. And we're glad that things turned out okay with your scare there and your hang gliding. Wow.
Yeah, I think of the Tim McGraw song, Skydive, but you know.
Oh, wow, that's crazy. And you mentioned Outer Banks. I think somebody is trying to tell me something about Outer Banks because I had a friend this morning say that she is going there with her parents in the fall. You were just talking about Outer Banks, and my brother texted a week ago that says next year he wants our family vacation to be a house in the Outer Banks. So I'm thinking I have to go there. So on to my rose and my thorn. I think they're one and the same thing. I have been considering for a long time going back to school myself. So Parker, I feel your pain there. You were talking about it, but I think I'm ready to start my DNP program. So it's a rose because that's exciting. I always love learning new things and I'm excited to get started. But I'm also feeling like it's a thorn because, oh my gosh, now I have to go back to school. I have to go back to reading and writing papers. And I'm a little overwhelmed with that prospect, especially because the program takes close to 3 years. So I think I'm going to try to get started this fall. So that's my rose and that's my thorn. Why don't we go ahead and move on to our topic? So today's topic is one that I suggested, adventures in wound care. And since it's my topic, I thought I'd start with a personal story. I didn't get into nursing to be a wound care nurse. I knew it was a part of nursing, and I can remember learning about wounds and how to dress wounds and how to pack wounds when I was in nursing school. But the first time that I saw an open chest wound, it really, really scarred me. But it also fascinated me to see how that was taken care of. So I was a brand new nurse. I remember walking in, it was an abdominal wound that had dehisced. So I knew what a dehiscence was and I knew what an abdominal wound was. But when I walked in and I saw the patient that was split from the sternum all the way down to his navel, just completely wide open, and you could see all of the different layers of fat, and you could see all of the different layers of muscle, it was just incredible to me that this man was still alive and talking to us. And I was watching the wound care nurse pack that wound. She was so calm and so careful and meticulous about how she was packing this wound and how she was educating the patient. I was so impressed. And it really started me thinking about, okay, maybe I want to learn a little bit more about wounds. And not just those kinds of wounds, but pressure ulcers. Obviously, those are a big part of our everyday life as a med-surg nurse. We see them more often than we'd like. I just thought that that might be a great topic for us to talk about here. Maritess, do you have any thoughts or experiences that you can share about wound care?
Wound care is a specialty itself. Kudos to our wound care nurses, but also kudos to our med-surg nurses who are learning wound care regardless how complex it is. And so as a clinical educator, when somebody would ask me, what is the training that we have provided to our nurses regarding wound care? There's always a question in my head, what kind of wound are we talking about? Because it makes me nervous all the time. Because when they ask that question, something probably happened. And as an educator, I take that personally because I know that we teach that in orientation. We teach that for our annual education. And so if something happens, my thought process is what went wrong, what was missed. And so I'm always concerned whether it's a surgical site infection or is it a pressure injury? And as we all know, it doesn't go well all the time. An article, it says that Lawsuits about pressure injuries would cost as much as $300 million for just a single case. Just one case can cost that much. And that's why it's so important that nurses are aware and understands how to really care for patients with wounds. None of us nurses wants to harm our patients, right? And so circumstances do happen without us knowing. But again, knowledge is important. Knowledge is power to be able to understand this situation. I've seen a lot of different kinds of wounds way back when I was still working as a physical therapist before nursing. But I always believe that wounds can always be prevented. We can always prevent it from happening. It's really the nurse's assessment and also patient education that would really help prevent any of these wounds from happening. As nurses, we need to use the tools that we have in the hospital. We are so well equipped with the devices. Talk about the different barrier creams that we have in the hospital, right? Every now and then, there's a new product to prevent wounds or to prevent stage 1 pressure ulcers. We even have our mechanical devices. We have the pillows, we have the wedges, we have everything that we can use to prevent pressure injury from happening. So I think as nurses, we need to be familiar what's out there that can help our patients and at the same time prevent wounds.
I personally love wound care nurses. I think that having those wound care nurses and having those wound care teams, wound care and ostomy teams, having that specialty in the hospital really makes a difference for patients. When I worked at UVA, we had something called PUP rounds. So that's pressure ulcer prevention rounds. And 2 nurses, they weren't wound care nurses. I was one of the nurses. And then we had another nurse that would do it with me. And we would go around and we would document every patient by hand with paper. But there's like a special paper that we had to fill out for all the patients. And the nurses on the floor loved it because we would be on the unit basically from 7 to 12, assessing their skin and helping out those nurses in the mornings once a month. But we basically put all of that data into a database that tracked how well we were performing pressure ulcer prevention and if there was a plan in place to address the wounds that our patients had. And I also think it's really cool, like seeing all the new creams and things that we have that are out now to help heal patients' wounds. And I agree, Maritess, prevention is key. But one thing that I found that's been particularly challenging, especially since COVID, is having the staff to help you turn those patients. When you have 6 patients and 4 of them are bedbound, it definitely takes a toll on staff and on the patients too. Those patients sometimes don't get the care they need. But I know whenever I have the opportunity to engage in pressure ulcer prevention, I take it. I don't care if I have to be in the room for 45 minutes. If I can get my patient turned and if I have the staff to turn my patient, I do.
Yeah, I think one of the most amazing things I've ever experienced in nursing was wound care that I helped perform as a CMA in oncology, and a patient had left themselves go and she had breast cancer, but essentially she had just kept packing her bra with paper towels, and eventually it came to the service and popped. And there's nothing like the smell of necrotic tissue, but we would have to pack that wound so deep. But wounds can just fascinate. And unfortunately now it gets so much harder because literally it's just about physically having enough hands on deck to turn people. Case of a guy who was a quadriplegic, and he had had a wound basically from the top of his back to his butt crack. All his skin had broken down because the nursing home he came in hadn't been turning him. And it's tragic to see those kind of things. And it is amazing what can be prevented when we invest in the time and energy and effort as opposed to a lawsuit.
Yeah, it's $300 million per lawsuit. And I do agree with all of you saying staffing, the tools. One of the rare types of wounds that I've seen is actually in the nose area. And that's primarily from the pressure. That's from oxygen. I think it's so important to understand or know where the pressure points are. I think we should have tools that will help move our patients. A good example I'll share is that perhaps our beds should have the capability to turn our patients, even though it's just one nurse or two nurses, I would say, or perhaps maybe use the Hoyer lifts or the Arjo machines. It's true. Staffing is such a huge problem. Also, one of the rare wounds that I've seen is in the condom cast, you can actually see like a wound in the penile area because it's been there and, it hasn't been cleaned. And so that's one of the rare ones that I've seen in the nose and in the genital area.
The devices that we put on the patient can also cause wounds. Like you said, the nasal cannula can create craters in the bottom of the nares. The Foley catheters can create pressure ulcers just outside the urethra. Even across the face, I've seen breakdown start across the face from the wires from the nasal cannula. CPAPs, BiPAPs, any type of device that can touch the patient's skin for a long time, if no one is pulling it off and checking underneath it there and repositioning it, it can lead to a pressure ulcer.
We had a patient once on that same oncology unit. He was actually a nurse and he had been recently diagnosed with lymphoma and he stayed in bed so long, he had a skin breakdown on his scrotum. There's lots of ways to get them.
If you ever want to know how to talk to your patient about wound care, follow your wound care nurse for an afternoon or just spend some time talking to those wound care nurses. They are so knowledgeable and they're so comfortable at the bedside with that education piece. So if you want to learn more about this, I guarantee you your wound care nurse will be happy to spend some time teaching you how to do that. I attended a class about nutrition and nutritional supplements. So when you have patients that are having issues with wound healing, I was amazed at how much of a difference nutrition can make. We don't always think about what part that plays in wound care, but we've got to make sure that our patients not only stay hydrated, but that they're eating the right foods. And if there is a supplement that's ordered for the patient, something to mix with water or to mix in their food, but it plays a big, big part in helping those wounds heal. So we can't forget about that part of our team.
That is such a good point, Laura. You reminded me that we need to always have a nutritional consult every time a patient has a wound, or if you think that this patient is high risk to have a wound, we should always have a nutritionist on board.
A high protein diet, which unfortunately the hospital's foods isn't always the best choice for it. So hence the supplements, like I said, whether it's the Ensure, the Boost, the add-ons into other drinks are so vital sometimes for wound healing, especially when we're looking at a diabetic patient.
Yeah, it definitely can be difficult for those patients sometimes to get those supplements down. But I say even if you can't eat a whole meal, at least get down your nutritional shake. One trick I like to try is with the chocolate Ensure. I'll mix it with chocolate ice cream and make them like a milkshake. A lot of the patients love that. Same with vanilla. Mix the vanilla Ensure with vanilla ice cream and kind of make a milkshake, calorie-dense snack that they can eat to just try to get some extra protein on board.
That's a great, great, great tip.
And that's yummy. Like some of them don't have an appetite, and that would really help. Thanks for sharing that.
Yeah, it's also a way that I can sneak in meds for my confused patients. If they have like an oral antibiotic or something like that, kind of just kill two birds with one stone.
Yeah, another thing I think you were talking about earlier, Parker, about the prevalent study that you did on your unit. It's a part of that nursing database, the NDNQI, which is the nursing database of nursing quality indicators, meaning that it's an indication of the quality of nursing that we're providing for our patients. So if you don't know what that is, the NDNQI, I guarantee you somewhere in your hospital, they are talking about it. There is likely a chart either on your unit or in your hospital somewhere, because they are looking at all of these different demographics, how well we are doing when we're assessing our patients, when we're discharging them. They're looking at our documentation. They're looking at the things that we're doing to prevent pressure ulcers, like Maritess was talking about earlier. It goes far beyond just turning our patients, but it's about that nutritional supplement. It's about using the preventive measures, recognizing when patients are at higher risk. Patients that are elderly have thinner skin and they're more likely to break down than perhaps somebody that's a little bit younger. But if you put that younger person in the OR for a 12-hour surgery and nobody's paid attention to the back of their skull on that hard table, we could end up with a tissue injury or a little bit of breakdown right there. So we have to be diligent when we're assessing the risk for breakdown that our patients have.
And I think it's so important to also know that in case you're not sure of the stage of the wound and you're not sure of how to assess, it's so important to tap with your wound care nurses. Documentation is so important as well, because that's how you monitor and see the progression of the wound, how the doctors can assess the next step. A lot of those points are so important, but I guess tapping into your wound care nurses, making sure that you know your resources just in case you're not sure and you're afraid to stage a wound or do something.
Yeah, if you're ever unsure, always get a second opinion. Bring a buddy in there, bring another nurse to take a look at it with you, or call the wound care nurse, but document it. Don't ever be afraid to document something. Wound care is just always a part of our ongoing competencies. I swear there is always some unit that's having an issue with wound care in some form or fashion. It's constantly needing to be looked at, and you're constantly needing reassurance that you're doing the right thing. And you also need to be held accountable to do the right thing. I know one thing that we were having recently is there were pressure ulcers that the patients were admitted with, but they weren't documented upon admission. It wasn't until a couple of days later that somebody actually thought to document the breakdown in the skin. So that now becomes a hospital-acquired condition, an ulcer that developed in the hospital, even though it has started happening before the patient came into the hospital. And the same can also be true when you're transferring patients from unit to unit. If you're not doing that good assessment when the patient gets to the unit, your unit then becomes the owner of that pressure ulcer. So it's always important to think about that. Whenever you're taking over a patient, you want to do a thorough skin assessment and be sure that you're documenting everything.
Laura, you brought a very good point, because that's true. If the wound is present upon admission, well, that's something that happened before you're taking care of the patient. But I've seen cases wherein nurses are held liable for such wound. Not to scare anyone, but that's the reality. If you saw the wound upon admission, document it. Because if you didn't document it, you didn't report it, and it's stage 4 or even stage 1, you have to really report that, because moving forward, you're really liable for it, especially if it starts progressing. I've seen it in the past based on experience as a clinical educator looking into cases. I take it personally. I always look into what was the gap, because we taught this in orientation. It was something that we wanted to really focus on. But if it's not seen or not reported to the wound care and the physician, that becomes your accountability. Thank you for sharing that. It's a professional accountability as well. You are responsible for your patient care.
Thank you, everybody. Well, believe it or not, we're just about out of time. But before we go, let's quickly summarize some of the things that we've learned. So nurses must work closely with patients and pay close attention to preventing pressure ulcer wounds. So patient education is extremely important. Become familiar with all of the tools that are out there that we can use to prevent wounds. Explore the idea of PUP rounds, pressure ulcer prevention rounds on your unit. And also pay attention to prevalence studies. I think prevalence studies are done either quarterly or annually, just to see how the quality of the wound care is going in the hospital. Also, it's important to know where the pressure points are on your patients to anticipate where wounds might appear, so you can assess the risk and work to prevent them before they happen. Pay special attention to devices that touch the patient's skin, which might be overlooked. And consider shadowing a wound care nurse to see how they practice and work with patients. Thanks for joining us. We'll see you next time. We look forward to connecting with you on the next episode of med-surg Moments, the AMSN podcast. In the meantime, we want to hear from you. Send us your questions, topic ideas, and feedback via our official med-surg Moments email address, amsnpod@amsn.org. That's amsnpod@amsn.org.
I'd also like to remind you to become a member of AMSN, or renew your membership at www.amsn.org. You receive lots of cool benefits and perks, such as discounted pricing on the annual convention, continuing education.
We encourage you to help us spread the word and subscribe to the med-surg Moments podcast via your smartphone podcast app to receive notifications of future episodes. Please be sure to leave us a review and recommend med-surg Moments wherever you get your podcasts to help us reach even more listeners.
I invite you to join the conversation by sharing your ideas and questions on AMSN's Facebook, Instagram, LinkedIn, or Twitter pages, and don't forget to add hashtag #MedSurgMoments to your post. Simply enter AMSN in the search field on any of these social media platforms to connect with us.
The content within the med-surg Moments podcast represents the views, thoughts, and opinions of the co-hosts and may not necessarily reflect the views, thoughts, and opinions of the Academy of Medical Surgical Nurses. Until next time, I'm Laura.
Neil.
Parker.
And this is Maritess. And always remember, med-surg Moments is a moment in our lives, a moment in our med-surg careers that makes a huge difference.